Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 435 of our pharmacotherapy series, which majors in breast cancer. This video discusses the case of CDC from part 434 of this pharmacotherapy series. CDC was diagnosed with a stage 2, estrogen receptor positive and progesterone receptor positive, HER2 negative invasive, or infiltrating, ductal carcinoma of the right breast. Her staging workup was negative as indicated previously with a negative CT scan of the chest, abdomen, and pelvis, and a negative bone scan. So my question to you is, based on this information, what would be CDC's likely treatment course? Let's begin by looking at local treatment, that is surgery and radiation therapy. Surgery is the definitive treatment in early-stage breast cancer. Many years ago, a more radical approach to the surgical removal of breast cancer was used. This approach, called a radical mastectomy, involved the removal of the entire breast, both the major and minor pectoralis muscle, and a full axillary lymph node dissection on the side of the breast cancer. Increased morbidity was associated with this approach, such as shoulder dysfunction and a poor cosmetic appearance. Today, a modified radical mastectomy is used that removes the entire breast along with an axillary lymph node dissection while leaving the pectoralis muscles intact. This approach leads to equivalent survival compared with the radical surgery. Radiation may be offered in addition to a modified radical mastectomy if the tumor is greater than 5 cm in size, if the patient has greater than 4 positive lymph nodes, or if positive tissue margins were present after surgery. This further improves the local control of the disease. These guidelines are widely debated and the subject of numerous studies evaluating patient populations who would benefit from adjuvant radiation therapy. Conservative approaches to surgery, such as lumpectomy, segmental mastectomy, or quadrantectomy, are also available. If a patient has a small tumor and wishes to preserve the breast, this surgical approach could be used. However, not all patients are candidates for this procedure. Those who are not candidates can include those with multicentric disease, numerous tumors throughout the breast, large tumors in relation to the size of the breast, and inflammatory breast cancer. If the decision is to proceed with breast-conserving surgery, the patient must also undergo adjuvant radiation therapy. Because the surgery only removes the primary tumor, the rest of the breast should be treated with radiation therapy to prevent recurrence of disease. Similar survival rates are observed with modified radical mastectomy versus breast-conserving surgery plus radiation therapy. Larger tumors do not preclude a patient from undergoing breast conservative surgery. However, to be eligible for this surgery, patients would receive neoadjuvant chemotherapy to help shrink the tumor to a size conducive to breast-conserving techniques. Neoadjuvant chemotherapy also allows the oncologist to assess response to treatment whereas the tumor is still in place and allows the opportunity to discontinue a particular chemotherapy regimen if the patient is not responding. Most patients will respond to chemotherapy. However, for those who do not, further chemotherapy, with a different regimen, or radiation therapy may be offered. The presence and extent of nodal disease is assessed through an axillary lymph node dissection. This involves the removal of at least 10 lymph nodes on the same side of the primary tumor to assess for the presence of breast cancer. Lymph node dissection may result in lymphedema, thromboembolism, and infection. Sentinel lymph node biopsy is one way to avoid the comorbidities associated with the axillary lymph node dissection. In this procedure, a blue dye, labeled with a radiocolloid, is injected around the breast tumor. Time is given for the dye to drain from the tumor to the lymph nodes. The surgeon is able to identify the sentinel nodes because of the presence of radiocolloid and the blue color. The breast, and presumably the cancer, drains first into the sentinel lymph nodes. Only 1 or 2 of the sentinel lymph nodes will be removed, reducing the risk of lymphedema, thromboembolism, and infection. Many consider this procedure the standard of care for assessment of the axillary lymph nodes. CDC could either undergo breast-conserving surgery plus radiation therapy or a modified radical mastectomy, but with CDC's family history she may also choose to undergo bilateral mastectomies to prevent the development of contralateral breast cancer. Next we will look at systemic therapy, that is chemotherapy, hormonal therapy, and biologic therapy. Surgery and radiation therapy eradicates most tumor cells. However, microscopic disease is difficult to detect and treat locally. Microscopic cancer deposits can migrate throughout the body and serve as sites for disease recurrence. To diminish the chance of recurrence, systemic adjuvant chemotherapy, hormonal therapy, and/or biologic therapy is given. The determination of which single modality or combination of therapies is based on the patient's prognostic factors: estrogen receptor, progesterone receptor status, and HER2 positivity. As mentioned earlier, tools such as the Oncotype DX genetic assay can estimate risk recurrence based on these tumor-specific characteristics and assist in determination of therapy. The size of the tumor and other prognostic factors are also evaluated to determine the course of therapy. The NCCN provides treatment guidelines to help with treatment planning. Patients with small tumors, that is 0.6 to 1 cm, and negative lymph nodes can be further divided into 2 groups based on favorable and unfavorable prognostic features. Favorable prognostic features would include hormone-positive disease. These patients can be offered hormonal therapy without chemotherapy. Those individuals with poor prognostic features, tumors with lymphatic invasion, high nuclear grade, hormone receptor negative, or HER2 positive disease, would be offered chemotherapy with or without trastuzumab therapy. Tumors greater than 1 cm in size are generally offered treatment with systemic chemotherapy. If the patient is estrogen receptor and/or progesterone receptor positive, they are additionally treated with hormonal therapy after chemotherapy. Biologic therapy with trastuzumab is added to chemotherapy if the patient has HER2 positive disease and assuming there are no contraindications such as cardiac disease. Patients should be fully informed of the absolute benefit of chemotherapy. because in those with early-stage disease the benefit from chemotherapy could be as low as 2% to 3%. The Early Breast Cancer Trialists Collaborative Group conducts an overview analysis every 5 years on the effects of chemotherapy and hormonal therapy in breast cancer randomized trials. In 2005, the 15-year survival updates were published. Although no standard regimen has been identified, combination regimens are superior to single-agent therapy. Recurrence rates and mortality for combination chemotherapy, respectively. Hazard ratio, HR, 0.77 with a p-value less than 0.00001 and HR of 0.83 with a p-value less than 0.0001, respectively. Single-agent therapy recurrence rates and mortality, HR 0.86 with a p-value equal to 0.0001 and HR 0.96 with a p-value equal to 0.4, respectively. Updated meta-analyses have also included the use of taxanes to fixed anthracycline-based regimens. In the previous EBCT-CG trial, taxanes were not included in the data analysis. With the incorporation of taxane therapy, breast cancer mortality was reduced. RR, event rate ratio, newer treatment versus control, is equal to 0.86, standard error, is equal to 0.04, with a p-value equal to 0.0005. This demonstrated the benefit of adding taxane therapy to standard adjuvant therapy for specific patients. Looking back at CDC's tumor characteristics, she has stage 2, that is 2.2 cm with lymph node involvement, estrogen receptor positive, progesterone receptor positive, and HER2 negative breast cancer. Based on this information, CDC would be a candidate for surgery and chemotherapy, based on the tumor size and lymph node positive disease, followed by hormonal therapy due to her estrogen receptor progesterone receptor positive disease. CDC underwent a right-modified radical mastectomy and axillary lymph node dissection. She had 2 of 15 lymph nodes positive for disease. Her adjuvant treatment will consist of chemotherapy, due to the larger size of the tumor and positive lymph nodes. So my question to you reads: what are typical adjuvant chemotherapy regimens for the treatment of early-stage breast cancer, and what should CDC receive? Many different combination chemotherapy regimens are used in the adjuvant setting. Anthracycline-containing regimens are commonly used. Doxorubicin or epirubicin in combination with an alkylating agent, cyclophosphamide, plus or minus fluorouracil is a typical regimen. In the most recent early breast cancer trialist, cancer group analysis, anthracycline-based regimens had significantly lower recurrence rates and death compared to traditional cyclophosphamide, methotrexate, and fluorouracil. Recurrence rate ratio 0.89 with a p-value equal to 0.001, and cancer death rate ratio 0.84 with a p-value less than 0.00001. respectively. A large pooled analysis demonstrated improved disease-free, with a p-value less than 0.00001, and overall survival, with a p-value less than 0.0001, with the addition of a taxane. Updated meta-analyses have also included the use of taxanes to fixed anthracycline-based regimens. As discussed earlier, the optimal taxane regimen has yet to be identified, and the full benefit of the utility of taxane therapy in lymph node negative disease is yet to be determined. However, the benefit is apparent in lymph node positive disease, and taxanes should be incorporated into the treatment regimen of those with lymph node positive disease. Congestive heart failure is a well-known toxicity associated with anthracycline chemotherapy. If a patient has heart failure or other pre-existing cardiac disease, anthracyclines must be used cautiously. To avoid potential toxicity, taxane regimens such as docetaxel and cyclophosphamide have been compared to a standard anthracycline-containing regimens, doxorubicin and cyclophosphamide. After 7 years of follow-up, both disease-free and overall survival were significantly better in the taxane arm compared with the anthracycline arm, 81% versus 75, with a p-value equal to 0.33 and 87% versus 82%, with a p-value equal to 0.032, respectively. Although the results are encouraging, these data do not have the track record of the anthracycline-containing regimens that are still considered the mainstay of therapy for adjuvant chemotherapy in early-stage breast cancer. Studies are currently underway to identify specific populations that may not respond to anthracycline therapy, thereby avoiding the risk of cardiac toxicity in these individuals. If these specific cases are identified, more non-anthracycline-based chemotherapy regimens will be incorporated into clinical practice. Based on CDC's lymph node positive breast cancer, a typical adjuvant chemotherapy regimen would consist of doxorubicin and cyclophosphamide, abbreviated as AC, or fluorouracil and doxorubicin and cyclophosphamide, abbreviated as FAC, given every 3 weeks for 4 cycles, followed by a taxane such as paclitaxel weekly for 12 weeks. Trastuzumab therapy can be incorporated into a patient's adjuvant chemotherapy regimen if the tumor is HER2 positive. Trastuzumab was first studied in the metastatic setting and demonstrated improved overall survival when added concurrently with chemotherapy. Because of its robust activity in the metastatic setting, it was then studied in early breast cancer to see whether the same benefit could be achieved. 2 large trials were conducted concurrently addressing different questions regarding the use of concurrent, sequential, and maintenance trastuzumab. Patients received the classic AC regimen for 4 cycles followed by paclitaxel weekly given either sequentially or concurrently. Trastuzumab therapy was started after the completion of the AC regimen to reduce potential cardiac toxicities associated with doxorubicin and trastuzumab. The results of these trials were combined and published in full. Disease-free and overall survival were significantly improved with the addition of trastuzumab, 52% decrease in recurrence rates, with a p-value less than 0.000, and 33% reduction in mortality, with a p-value equal to 0.015, respectively. 4-year follow-up data continued to demonstrate significant improvements with trastuzumab compared to chemotherapy alone. Based on these data, trastuzumab was approved for use in early-stage HER2 positive disease after the completion of AC therapy followed by sequential paclitaxel therapy for 1 year. The use of maintenance trastuzumab was further studied in the HERA trial, Herceptin adjuvant trial. In that trial, patients were randomly assigned to complete 1 or 2 years of maintenance trastuzumab therapy. 1 year of trastuzumab therapy is the current standard of practice for maintenance therapy in the adjuvant setting. Because CDC does not have HER2 positive disease, trastuzumab therapy should not be used. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 436.